Well, it's really a singular honor to be asked to speak at the Thomas Galerter Lectureship. I've known Tom for many years, and for me, he has always been the epitome of a thoughtful, decent, and wise person. You know him better than I do, since you've had the wonderful opportunity to work with him for all these years. But he stands out to go back to my roots in New Jersey. He is a true mensch. So let me talk to you a little bit about genome testing in clinical medicine, wearing green eye shades with our rose-colored glasses. So the idea here is we really need to think about how genomic medicine is going to be applied to clinical medicine. There are wonderful opportunities. We hear a tremendous amount of hope, a tremendous amount of hype, and also a tremendous amount of naysayers. It all depends on what audience. I think it's very valuable sometime to go and give a talk about genomics to a group of general internists. This is not this audience. It's a very, very different audience. And they are very skeptical and want to know, really, how is this really going to help? And is it worth the expense? And I think that that is a valuable, skeptical approach that they take, and we need to respond to it. So first of all, what's personalized medicine? I thought I would just borrow this quote. I don't know if you've heard of this guy. His name's Francis Collins. He had an interview back in 2005 about what personalized medicine is. That's the most basic. Personalized medicine refers to using information about a person's genetic makeup to tailor strategies for the detection, treatment, or prevention of disease. I'd like to go over some myths about genomics, and these are ones that I feel are really important and are a problem in the field. One is that basic research findings are easily and quickly translatable into clinical applications. Nobody thinks that a fantastic finding in C. elegans biology or genetics is going to be immediately translatable into clinical medicine. But somehow, human genetics, because it's human, even though it's just as much of a basic science as yeast or worm genetics will be, still people seem to think that it's immediately translatable. It's not. Second is that genomics is so cool, you don't need to gather the effectiveness data needed for the translation pathway. It's sort of this famous comment, as any fool can see, and then you proceed to, you follow that with what it is that you want to say, and if anybody objects, you've just called them a fool. The patient and providers of genomic testing get to decide what's useful, while the third-party payers and the governments are just delighted to pay for it. Another big myth. And then finally, that technology will solve all these problems. And I actually don't think technology will. I think it's a combination of great technology, but it's also going to require some shifts in our culture, in our societal norms, and in our thoughts about ethics. So what I'm not going to be talking about, I'm not going to talk about applications in basic research, in gene discovery or pathogenesis. I'm not talking about that at all. I'm also not going to talk about any companion diagnostics. I'm not going to touch on tumor sequencing. That's a whole field in itself. And you have one of the foremost people in the world in Arul Shinayan working on this here at University of Michigan. And then I'm not going to talk about other sorts of omics like transcriptome profiling. I'm just going to talk about genomics. So, current and future applications of genome analysis across the lifespan. So you can think of it, first of all, in terms of different stages of life, thinking about having children, preconception, prenatal testing, newborns, children, and adults. And also, I think it's very important to distinguish between diagnostic testing when there's an indication versus screening, where you're looking for things in essentially asymptomatic people. Those are two very different settings. They require two quite different approaches to things. And the way I think many of us think about this is really was formulated by Moon Curry and his group at the Centers for Disease Control. And that's what they call the ACE framework. I'm sure some of you, maybe most of you have heard of this, but I just thought I would go over it with you. ACE stands for analytic validity, clinical utility, and ethical, legal, and social implications. And I think this is very valuable, and I can't tell you how often I hear people talking about genetic testing. They confuse analytic and clinical validity. They don't know exactly what they're talking about when they talk about utility. And so I think it's a good idea to frame our thoughts about this using the ACE framework. So what is analytic validity? It's getting the right result from the right patient. And this is really where sensitivity and specificity comes into account. false positives, true positives, false negatives, etc. And also getting the right result from the right patient, just making sure you didn't mix up the tubes and all the other sorts of stuff that the CLIA cares about. Clinical validity is something else. It's given a result, assuming that you've got the right result from the patient. What does it predict? What does it mean? And here we're talking about, in genetics, we often refer to that as penetrance, but we also are talking about positive and negative predictive values. Given a test, what's the likelihood that the patient will have a disease or be susceptible to it? And given a negative test, how successful is it at ruling it out, the rule out in medicine? Clinical utility is very fuzzy. And there are a number of different definitions, everything from what the genome libertarians who live in the Silicon Valley believe is that anything that is amusing or satisfies one's curiosity about one's genome is utility. It's personal utility. I'm curious about whatever. And that constitutes clinical utility. The third-party payer says, that's fine, I'm glad to hear that that's useful to you, but it's not useful to us, and we're not going to pay for it. So if you want that, fine. Write a check, give them your credit card. But don't expect us to pay for anything that is not actionable, meaning changes the way you and your physician are going to treat you and treat your family. So actionability is sort of at one end of the spectrum, satisfying personal curiosities at the other end of the spectrum, and utility falls anywhere in between those, depending on who you talk to and what time of day and what day of the week. And then finally, the societal value in having the test results. What are the ethical, legal, and social implications in terms of cost, lost opportunity to do other things? Remember, every dollar you spend on healthcare is a dollar that's not being spent on something else. You could say that it's a dollar not being spent on bombers. That's a good thing. You could say it's a dollar that's not being spent on childhood vaccinations. That's not such a good thing. As well as ethical, legal, and other implications. So analytic validity, true and false positives. Can you find an abnormality when it's there and not find one when it's not? And just to remind you what sensitivity and specificity are, because I'm continually surprised at how much people confuse sensitivity and specificity with positive and negative predictive values. So sensitivity and specificity are in people with a disease, how often is there a pathogenic mutation in a relevant gene? And specificity in people without the disease, how often is the gene sequence normal? Simple, right? No. For some variants, yes, we know exactly what those variants mean. For others, no. Because the sensitivity and specificity all depend on correctly interpreting whatever variants you find. And as you know, and as I tell all my patients, whenever I do a genetic test, I tell them there are not two results with genetic tests, normal and abnormal. There are always three, with the third one being variants of uncertain significance. We don't know what the variant means, if it has any implication for you at all. And interpreting variants ultimately requires correlating genotypes with phenotypes. And that's something I'm going to talk to a little bit more later. Now, if you don't have phenotypic correlation, in other words, what typically happens if you do a screening, like a whole genome sequence on a healthy individual, and then you look in the genome and try to find variants and figure out what they mean, you don't have any correlation. There's no phenotype to correlate with. So you rely on what's essentially a proxy for pathogenicity. Pathogenicity meaning disease causing. And the proxy is the mutation deleterious? What does it do to the gene function? But I think it's important as a mental discipline not to confuse deleteriousness with pathogenicity. There are plenty of examples where a mutation can completely destroy the function of a gene without causing disease. So don't confuse those. We can infer pathogenicity from the frequency of the variants in databases of allegedly normal people. So, for example, the EXAC database of Dan MacArthur is wonderful. From the Broad Institute, something on the order of 75,000 exomes that you can look at allele frequencies. We know next to nothing about the people in that database, what their phenotypes were. And as we all know, particularly for dominant disorders with decreased penetrance, there can be lots of people walking around who have what would be, in some settings, a pathogenic mutation, and in others, completely without any consequence. And penetrance estimates are very uncertain. There are very few examples where we've been able to do a direct head-to-head comparison of the same variant detected in a clinical setting where there's an affected person and family members versus pure screening, where there's no phenotype at all. I mean, one of the best examples that has been looked at has been the 3 Ashkenazi Jewish mutations that are known in BRCA1 and 2, where the estimates of penetrance there for BRCA1 is as high as 80 or 85% when calculated in families, heavily loaded, but in population-based screening, the penetrance is closer to 60%. Still 5 times higher than the population frequency of breast cancer. So it's not as if the penetrance drops to insignificant, but they're not the same. And I think this is a concern that we have to have in thinking about applying genomics widely, particularly in people who don't have a condition and don't have a family history of that condition. So what are the challenges to bringing phenotype to bear on interpreting human variation? So you do the best you can. You look at frequency in databases. You look at whether it's a deleterious mutation. You may even do a functional study in vitro to see whether if you model this mutation, I was talking to Miriam a little earlier today, in a sodium channel, let's say, and then ask, can you detect an abnormality? That's all very powerful information, but it's disconnected from disease. So how do you connect it to disease? Well, you have to have a connection, a correlation with clinical-based phenotyping. And the problem there is our health information systems were perfectly and beautifully designed to take care of appointments and billing. They were not beautifully designed for doing research. There's a fragmentation of phenotypic information among these inadequate systems. So it's hard to get all the information together. Anybody who practices genetics, you know, I have a person sitting in front of me in California whose parents live in Ohio and whose grandparents are in Arizona, and it's just on and on and on. There's difficulties in capturing environmental and social determinants of health. I think we in genomics have tended to be guilty, I think, of a little bit of hubris in overestimating the role of genetics. I know my favorite example of this is in the pharmacogenetic area, where I've been very interested in pharmacogenetic variants that affect drug metabolism. But you know, if the patient's a little bit forgetful, and they forget to take their drug that day, or they forgot they took it and they take it again, that is just as likely to cause a serious adverse event than whether their cytochrome P450 metabolism is 50% of normal. So you really have to take these things into account. And finally, the tension between individual rights to privacy, the need for data sharing, and economic factors that drive the hoarding of information. And I have a particular, I never give a lecture without at least mentioning for at least 30 seconds that there are some companies that believe that the genetic testing that they did is their own personal property, intellectual property, and they will not share it and will not allow people to investigate. You called this variant benign. Why? What's the basis for your call on that? And I think this is a real drawback, and I just want you to imagine the following scenario. Röntgen examines X-rays, discovers X-rays, and then everyone around the world who starts taking X-ray pictures doesn't publish a single X-ray. Everyone keeps all their X-rays hoarded in their own little radiology department. How much progress would we have made in being able to understand what these X-ray images mean under that scenario versus one in which the images are freely shared? Okay, so this is a big table, and I apologize for how big it is, but it's sort of a schematic of the sorts of factors that go into variant interpretation. Everywhere from saying we think it's benign to we think it's pathogenic, and sort of steps in between. And what are the sorts of criteria we look at? We look at population data, look at the minor allele frequency. If it's too high for the disorder, or it's observed in controls that's inconsistent with disease penetrance, it's very likely to be a neutral benign polymorphism. Whereas the penetrance in affecteds is statistically increased over controls. You keep seeing the variant over and over again in people who are affected with the disorder. And of course, the most obvious ones are ones where you never see the variant. in somebody who isn't affected. And we have perfectly good examples of that. Someone who is homozygous for one of the common Tay-Sachs mutations, we know very well what that person's phenotype is going to be. Computational data. And there's a lot of work being done on this. I want to do a call out to Stephen Brenner at Berkeley, who has this thing called the CAGI project, C-A-G-I, where he collects sets of variants in genes where the answer is known as to what the effect of the variant is on gene function. It's known through functional studies, a whole variety, but these are completely unpublished. So you submit this data set, and then anyone can come in and say, I'd like to check this data set and run it through my in silico testing. There's no limit, there's no holds barred, do whatever you can, so that in fact if the variants are published, people can go and find what was asserted about those variants, which is why these all have to be unpublished. And it turns out to be very, very interesting differences in different approaches, machine learning versus other sorts of approaches. But we are a long way from being able to do automated computational analysis of variants across multiple genes. In each gene, I think we have better and better ideas, from analysis of domains, analysis of active sites, analysis of protein structure. But to think of a common in silico approach that's going to give you the right answer, right enough to make a decision about whether you're going to do a bilateral mastectomy or not, we're not there with in silico approaches. Functional data, very important. Well-established functional studies show that there's no deleterious effect versus well-established studies show there's a deleterious effect. Segregation data in families, very important. Does it segregate? Do you have a de novo mutation? Of course, you have to make sure that you know the paternity, because it may not be de novo, it just may be a surprise. Allelic data, other sorts of databases, other sorts of data. For example, in BRCA1, the vast majority of compound heterozygotes for deleterious mutations in BRCA1 is an embryonic lethal. And in BRCA2, it's Fanconi's anemia. And so that if you have a patient who you know has 2 mutations in trans and does not have Fanconi's, one of those BRCA2 mutations is not going to be particularly deleterious, or if it is hypomorphic, is only slightly so. And for recessive disorders, if they're detected in trans with a pathogenic variant, then I think you can feel pretty confident that that variant is also pathogenic. So these are the sorts of things people are using, and we're attempting now in the ClinGen project, part of the of which ClinVar, the database, is part, to try to develop a reproducible system that is quantitative, where we can apply some sort of quantitative tools, something as simple as a point system, and others were trying to do something a little more sophisticated, to try to develop a consistency. Why is that? It's because we're having trouble. This is the consortium for the CSER consortium for sequencing that the NHGRI funded. This is data I got from Heidi Rehm, who's a collaborator and friend from Laboratory of Molecular Medicine. So they took 6 variants chosen from those identified during incidental findings analysis in the ESP cohort. This is Debbie Nickerson's cohort of heart disease patients. These variants were then shared with 6 CSER sites. The variant was assessed by groups independently, and then the results were compared and presented at a meeting in 2013. There's a second round of this that's also been done, but it's not been published yet that I know of, so I didn't want to show that because it's not my data. So these are the results. Here are the 6 mutations. Here's a premature termination in MSH6 and Lynch syndrome. Here's fibrillin 1. There's a missense mutation. This is the Marfan, TN2. This is a cardiomyopathy. RYR1, this is malignant hyperthermia. LDLR, this is the LDL receptor. And TSC2, this is the tuberous sclerosis, one of the 2 loci. Those are all missense mutations. And this is how they were viewed by 6 different sites. So, number 1, termination. Everyone said there was going to be pathogenic. We know that loss of function in this gene causes Lynch syndrome, although with very variable penetrance. FBN1, well, VUS. Here, 2 people in the same lab said, one said it was likely pathogenic and the other said it was a VUS. VUS, likely pathogenic. This lab, two different people, one called it pathogenic. This is slam dunk diagnosis of Marfan syndrome. And this person said likely pathogenic. This one, VUS, why? Because we know so little about TNN2, and I think everyone just sort of throws up their hands and says, I don't know what these variants mean. RYR1, not completely consistent, although at least likely pathogenic versus pathogenic. The LDL receptor, this one person here thought it was likely pathogenic. One person here says it's likely benign. And here the same. These are not unsophisticated people. These are all molecular diagnostic laboratories who are doing clinical studies, clinical exams on a regular basis. And this is data, by the way, from Gail Jarvik, which I'm very thankful to her. So, how good are we variant interpretation? Is the variant interpretation reproducible between labs? Mostly, but not totally. And any of you who work in a clinic where you've sent off a molecular diagnostic test have had an experience of getting a result, looking at it, and then looking at the justification that they give for annotating the variant as they do, and you disagree with it. So what I do when that happens is I call up two other labs that offer the same testing, as long as it's not the lab in Salt Lake City that doesn't like to talk to you. Otherwise, the other labs are happy to talk to you, and they will give you their interpretation of that variant. Well, doesn't it make sense that all the labs ought to just put all that into a central public database where it can be curated? Yes, and that's what ClinVar is about. ClinVar is growing like crazy, and my hope is that we'll have hundreds of thousands of clinically significant variants interpreted by laboratories. And we can put them head to head. Two labs interpret it differently, then that is noted. There's a flag that says discrepancy. Whereas if 6 labs all say it's the same thing, and an expert group gets together and says, we agree, this is a benign variant, then it gets 5 stars and it's pretty much considered correct. So we have to get this data and we have to get it together in a place where it can be looked at. This is part of what I mean about cultural changes. This is not I mean, it's partially a technological problem, a database problem, but it's mostly how do you overcome the inertia of a laboratory to submit data to ClinVar? I mean, why should they do it? They're not being paid to do it. They're doing it out of the goodness of their heart because they think it's good for the field. Well, good for the field only takes you so far. And so I've made a recommendation to the FDA. They are going to be regulating laboratory-developed testing, including all this genomic testing. They've announced they're going to do it. Exactly how they're going to do it isn't clear, and they're going to fade it in over 9 years. But I've made it a suggestion to them, which they think is reasonable, and that is submitting your data to a public database so it can be reviewed by the FDA, because the FDA is going to be deciding about clinical validity. That's going to be part of their decision about whether they're going to allow you to offer the test or not. I mean, if you look at the stuff that the FDA has written announcing this, ClinVar is all over their articles. They're going to rely on this database. So I think they should make it a requirement. If you don't submit your data to ClinVar and make it public, you don't get to do all clinical testing. And I think putting that kind of regulatory strength behind it is the only way to do this. Do we know how to interpret every variant we find? No, but it's getting better as the databases grow. And what are the obstacles to improving? The sheer volume, the difficulty of obtaining phenotype data. You often get a test that comes into a laboratory where it says, rule out such and such. That's all the information you have. Fragmented health information, privacy, proprietary databases, and more. Okay, so let's go on now and talk about diagnostic testing in childhood, infancy, childhood, and adults. So this is sort of the way I put it together and I view about where things stand now currently in deciding on what test. It's a question I'm often asked by clinicians who want to do some genetic testing. What test should I order? Should I just do an exome? Just do a whole exome or do a whole genome? Why not? So this is how I kind of put it together. Back in the day, originally, when Y.W. Kahn and others started to show that you could detect the sickle cell anemia mutation, you've got a very high prior probability of specific diagnosis, sickle cell anemia. And there's a very limited variant and locus heterogeneity. There's essentially one allele in one gene. So you could test one allele in one gene. However, once you start getting up to, let's say, BRCA1, here you have a single gene, but there are multiple alleles. Then you get to high-risk breast cancer, where you have to add BRCA2, as well as a number of others, and develop gene panels. Then you get to hypertrophic cardiomyopathy, where you need dozens of genes to be able to cover the loci that are responsible, with many, many different variants. And then finally, you have a situation where something like developmental delay or a previously unknown multiple congenital anomaly situation, where you have no idea what variants are involved, how many there are, how many loci there are, et cetera. Well, their exomes and genomes are becoming clinical and being used regularly as I wouldn't call it quite standard of care, but being used widely. So gene panels versus whole exomes and genomes. Panels give you an average of about 400x coverage. There's great completeness for the genes tested, but not all the relevant genes are known and therefore may not be covered. Whereas for a whole exome, whole genome, you have near exome or genome-wide coverage, but typically 30 to 60x, and there are holes in it. There's a friend of mine who likes to refer to the whole genome as HOLE, as opposed to. So panels, diagnostic advantages of panels. They target specific indicated genes. The sequence of the exons are all delivered unless otherwise specified. Deletion duplications are all delivered. A negative result approaches being a true negative, but only for the genes on the panel. And you also have to be aware of false negatives due to deep intronic mutations, which are not searched for in any clinical laboratories. I've had at least 2 retinoblastoma patients who had lariat branch point mutations 35, 40 bases upstream of an exon in the intron that were just not covered. Why use gene panels? Clinical utility. Here's an example. This is a paper published by Desmet all this year. 1,046 individuals qualified for hereditary breast and ovarian cancer evaluation and who lacked BRCA1 and 2 mutations. So they'd already been tested for the 2 big ones. An additional 4% had mutations in other breast cancer risk genes, including CHEK2, PALB2, ATM, and the Lynch syndrome genes. Of those, 50% of these resulted in a new actionable procedure. If you find a family that looks like hereditary breast and ovarian cancer, and it turns out to be a Lynch syndrome family, you now have colonoscopies and other things that need to be done that change the care of the patient. And 3/4 led to cascade family testing to identify other at-risk individuals or other people in the family who needed to be examined and tested. And this paper was followed up by a very nice editorial by Elizabeth Swisher on usefulness of multi-gene testing, catching the train that's left the station. Why use gene panels? Clinical utility. Here's another paper. This is from Fergus Couch from Mayo Clinic, who's really one of the best people in this area in hereditary breast and ovarian cancer. They looked at 1,800 patients with triple negative breast cancer, unselected for family history. So all they had was triple negative. By the way, this does not qualify under most third-party payer guidance. This would not qualify for them to pay for any kind of testing in the absence of a strong family history. Deleterious mutations were identified in 15%, almost 15% of patients, of which about 2/3 were BRCA1 and 2, and then other deleterious mutations in about another, once again, about 4% of patients, with a majority involved in homologous recombination pathway, including PALB2, BARD1, etc. Why is this important? First of all, it's important for family counseling. It's important for being able to make predictions about other sorts of events that the patient might be at risk for. It's also important because there's now a whole developing story of the use of certain chemotherapeutic agents in patients whose breast cancer or ovarian cancer is due to a defect in BRCA1 or 2. They're calling that BRCA-ness. And being a PALB2 mutation carrier also has BRCA-ness due to homologous recombination pathway, which seems to be synthetically lethal with PARP inhibitors. So it really has an effect on how you treat the patient. So here's breast cancer, genetic topography. This is from 2014 from Doug Easton. but it pretty much fits the picture. So here's allele frequencies across the bottom, logarithmic, and here's relative risk. So here's BRCA1 and 2. They have the highest allele frequencies compared and relative risk. They sort of win in that area, although PALB2 is pretty close. CHEK2 and ATM are here. So panels that include these genes constitute highly effective and cost-effective approaches to evaluating families with hereditary breast and ovarian cancer. In comparison, here are SNPs, much more common with very small relative risks. And the reason I bring this up is I just wanted to show you this distribution of risk alleles in over 33,000 controls and almost 34,000 breast cancer patients. These are, look at the risk allele counts. We're talking about up to 80, 85, 90 risk alleles. Obviously, there's a tiny tail here of people who have all the risk alleles, and there's a tiny tail to have very, very few. But the overlap between these two curves is so high, the receiver operating characteristic for this is essentially close to 0.5 slope, and so the area under the curve. And so I don't think at least in this area, these sorts of use of SNPs, which is very useful for basic science and for trying to understand something about breast cancer, have very little clinical validity. They're not going to help you predict who's going to get breast cancer and who isn't with any kind of precision. Cardiovascular, this I think points out some of the drawbacks of panels. Long QT over 12 genes, pretty good detection rate. Brugada, less than half with the genes we know. Hypertrophic cardiomyopathy is pretty good. Dilated cardiomyopathy, over 40 genes involved, and yet that's only 40% of the yield. We're missing a lot. Autopsy negative sudden cardiac death, we're still missing 2/3 of them. We don't know why these people died. And ARVC, we're also missing about half. So panels have its drawback, which is that if you're in a period of rapid development of knowledge and understanding about a disorder, you have to realize that that panel just may not contain all the loci that you would want. Of course, I just want to reiterate this problem. So here are 4 different panels from one of the companies, not mine, one of the companies that provides these panels. These are increasing or slightly different sets of genes, with the cancer panel being kind of the union of all of these. It's just every cancer gene they can find. In blue are all the ones where they did the test and couldn't find anything of any significance. And yellow are the reds, so we're getting a yield of somewhere around almost 10% here. But look at this, inconclusive. So you have to go into these tests realizing, and this is just a panel now, we're not talking about a whole exome. In just a panel, you have to recognize that almost 1/4 to 1/5 of the time, you're going to find something in one of those genes that you can't interpret. You don't know what it means. And what you've done is you've inserted anxiety and uncertainty into the patient's mind, and also the opportunity for misunderstanding. I've had to dissuade at least 2 patients from having bilateral mastectomies when they had VUSs in their BRCA1 and 2 genes. The vast majority of those VUSs, by the way, are reclassified as benign as time goes on and we learn more about it. Whereas whole exome sequence has a diagnostic advantage of you can discover new genes involved in known disease phenotypes. And you can also define new disease phenotypes caused by genes previously not known to even cause human disease. So the opportunity to make new discovery is much greater here. So here's a recent paper, Farwell et al., looking at the application of whole exomes in the setting of undiagnosed diseases. These are primarily neurological disorders where we don't have a handle on what's going on with these patients. And the yields are pretty good. I mean, we're talking about 30% of patients had a positive or likely positive, meaning explanatory result. A novel gene, one that was not known to cause disease before, was found in 7.5% of patients. The highest diagnostic rates were in patients with ataxia, multiple congenital anomalies, and epilepsy. 23% of the positive findings were within genes characterized within the past 2 years. That's just a phenomenal piece of data. that 2 years ago, we didn't even know those genes were associated with disease. That's how fast. Do any of you participate in MIM match, M-I-M match? You should do it. Go to the OMIM site. You do it. Go to the OMIM site and sign up for it. What you can ask for is to get an email every time an entry in OMIM changes. And so it's like Twitter for nerds. It's just great. I use it. I love it. I usually get a message about 2 or 3 times a week. That's all. But what's just amazing is 5 new genes for condition X, 1 new gene for condition Y. It's just fantastic how rapidly the application to Mendelian disorders is discovering new human disease genes. Okay. So diagnostic drawbacks. The analytic validity with whole exome and genome is a problem. Insertions and deletions may be difficult to score, and you just may not find out about them. You may not get full capture, depending on what platform is used, so there may be exons that you just don't know about. Whereas with a panel, they guarantee you that you'll see every exon, you'll see every exon. And which genome build and transcript reference used affects coding variant detection. There's some beautiful examples of that, where one of the labs went to the new genome build, and all of a sudden a bunch of variants that they thought were all pathogenic turned out to be intronic. But here's an example of work that's being done. This is from Sarah Garcia, who works with a company out in California. What they're doing is going through, here's one gene, doesn't matter what it is. They went through and did the exome capture using a standard NimbleGen platform, and then they deliberately fill in those areas, particularly in the coding, where the capture is not that good. They fill it in with extra baits and do some different chemistry, and you can up your capture. So exomes are improving, they're getting better and better. But here's an example of clinical exome sequencing for genetic identification of rare Mendelian disorders. The JAMA paper in 2014. They looked at 814 patients, and they made a diagnosis in 213 and a potential diagnosis in 228. So that is 54%. It's phenomenal. And what's also very interesting, and they find this over and over again, is there are patients that have 2 Mendelian disorders. And the reason that they weren't diagnosed was because their phenotype was the union of 2 phenotypes, and it was even the best of clinicians. I mean, even Jeff Innes here might have difficulty dissecting out these 2 phenotypes and realizing the patient had 2, whereas the whole exome sequence drops it in your lap. Now, this brings up, however, the other problem with whole exome and whole genome, and that is incidental or secondary findings. These are results not related to the indication for the test that are discovered in the course of a diagnostics test, but they still may be of medical value. I mean, if you're going to search every exon of every gene to see why this patient has severe epilepsy, you're going to take a look at BRCA1 and 2. You're looking at all the genes. And so the idea was, are there certain genes where you shouldn't just be stumbling on the variants? You should actually deliberately look for pathogenic changes, even if it's not part of the indication. Do such genes exist? What are they? What should they be? And I participated in a committee. We used to call the handouts for medical school, called them camels. And the reason they were camels is because they were horses designed by a committee. So this is a horse designed by a committee, which is incidental and secondary findings, ended up with a list of 56 genes and 24 conditions that they recommended, they meaning I and others, clinical laboratories have an obligation to actively seek out in the course of doing whole exome and whole genome sequence. And the idea was that if the lab finds one of these and it's medically relevant, that it's unethical to withhold that information from the patient, even though that's not why the test was being done. That this duty supersedes patient autonomy, so you don't ask the patient, do you want to know this or not? You have to report the result back to the clinician, and it's the clinician's job then to talk to the patient and say, do you want this information back or not? This was for the laboratory personnel. And the recommendations including reporting test results for adult onset conditions to the parents of children undergoing whole genome whole exome. So in essence, ACMG report recommended that certain incidental findings be actually secondary findings. You ought to search them out and look for them. This led to a certain amount of controversy, um, many ethical concerns about the clinical validity and the clinical utility of some of these findings. Um, uh, Wiley Burke worried about that some of these genes have unknown natural history, that we're not sure what the penetrance is, because in many of these, the variants were from families, whereas these are being found incidentally, which may be different. Phenotypic spectrum and penetrance not always known. Lack of controlled studies. Prior probability of disease is low. Cost should not be generated if the patient don't want the results. And as a result, ACMG did a little backtracking and said the patients should be given the choice to opt out before testing takes place, so results that they would wish not to receive are not generated. This is very interesting, but I just wonder how many people who, for example, order a microarray for deletions or duplications for a child who has multiple congenital anomalies or developmental delay, warn the patient in advance that we may find something that has nothing to do with your autism or your developmental delay in your child, but is of medical relevance. I'd say very few, very few. I've had 3 cases now in the last 5 years of being referred children who had microarrays done for developmental delay. One had a deletion of the VHL gene, and 2 of them had deletions of TP53, the Lee-Fraumeni cancer syndrome gene. And we had to then do the counseling post facto that there were serious findings here that have nothing to do with why the test was originally ordered. So, incidental findings, there are either none or many fewer in panels, because with panels, there's a set of genes that you're asking about, and you want to know what the results are. The last thing I want to talk about a little bit is about screening. So in screening, you really have to worry about the positive and negative predictive value, because there, it's not just sensitivity and specificity, it's the sensitivity and specificity applied to a population where the incidence of disease may be quite low. And if it's low, and your specificity isn't really, really high, then pretty much everyone you find is a false positive. So just for an example, suppose you have a disease, a test that has a sensitivity of 0.9, a specificity of 0.95. Here's a positive predictive value, depending on what the disease prevalence is in the population you're studying. Pretty good if it's 1% of them, but if it's down to 1 in 10,000, 99.8% of all your positives are false positives. So the last thing I want to talk a little bit about is the clinical utility. So I've spent most of this time talking about validity. If a genetic test result is clinically valid, is the information valuable and useful? And I can't tell you how many times I've heard this phrase, pharmacogenetics is the low-hanging fruit. I don't think it is at all. So here are the list of the current May 2015 FDA boxed warnings that talk about pharmacogenetics in the drug label. So a couple of them, abacavir, if you're HLA-B 5701, you're at risk for severe reactions. I'll show you that in a minute. Polymerase gamma mutations put you at risk for severe results from these anti-epileptics, valproic acid or divalproex. But these are the 2 that I think I really want to focus on. One is clopidogrel, which is used in cardiology as an antiplatelet agent. There's a boxed warning, dosage and administration and precautions, and codeine for those patients who are ultra-rapid metabolizers. In both of these cases, these drugs are prodrugs, which have to be activated by cytochrome P450. So for abacavir, an HLA-B 5701, this is a perfect example of how things can work. So this was a paper published back in February 7, 2008, where they put on top of an already existing study of genotyping in patients who had received abacavir as antiretroviral therapy. What they found, this, by the way, this is toxic epidermal necrolysis. This is the Stevens-Johnson syndrome, a less severe form of this. But this is what happens to people who have that particular HLA-B type with a positive predictive value of 50%. So half of the time, this is what's going to happen. So it was a global multi-center study, looked at 2,000 patients, and then they looked at them, and the result was Screening reduced the risk of hypersensitivity reaction to abacavir. In predominantly white populations, 94% of patients don't carry this allele. They're at low risk, so it's a very good negative predictive value. And 6% who do carry it are at 50% risk for hypersensitivity. So here's a pharmacogenic test that can be used to prevent a specific toxic effect of a drug. There's a similar relationship between a different HLA type and a toxic epidermal necrolysis response to carbamazepine, which is another epileptic drug. Very high frequency of that allele in people from Asia. And so that, for example, in Singapore now, they're essentially screening everybody for this HLA allele and have that information available, whether the patient's going to get carbamazepine or not. And they've reduced the incidence of Stevens-Johnson syndrome or toxic epidermal necrolysis in response to carbamazepine therapy down to minuscule levels. So there's a population-level screening which really works. And what's nice about this is that abacavir study, the PREDICT study, was published in February 7, 2008. Within 1 year, standard of care. Don't give abacavir unless you've tested HLA-B5701. So that's kind of the poster child for pharmacogenetics. The problem is codeine. For example, prodrug, CYP2D6 activates it, turns it into morphine, basically, although there are other complicated pathways. So here's the recommendations. Use alternative analgesics to codeine in patients who are CYP2D6 poor or ultra-rapid metabolizers, whereas these other drugs like oxycodone, hydrocodone, and tramadol may be some reduced efficiency or there's insufficient data to support it. So does this mean that we should test everyone for CYP2D6 before you give them codeine? It's going to take a week to 10 days to get the result back. It may cost $1,000 or more to get the test. No. Just don't give codeine to children and don't give codeine to nursing mothers. That's the recommendation. So they're completely bypassing the genetics and just saying there are alternatives. There are cheap alternatives. Clopidogrel is the same problem. 2 to 14% of the US population are CYP2C19 poor metabolizers, so they cannot convert clopidogrel into an active compound. So there's overwhelming evidence that the poor metabolizers don't activate this drug to its active compound, but there have been over 12 studies looking at outcomes using pharmacogenetic guided drug choice to prevent major events or stent thrombosis, and they're contradictory. So there are some institutions like Vanderbilt that has instituted CYP2C19 genotyping and making it available through the medical record in anybody who they think might get clopidogrel. Whereas in my institution, the cardiologists just laugh in my face and say, go away. There's nowhere near enough evidence to support all of the pain and effort it's going to take to do this sort of genotyping. If I'll check the clopidogrel, and if I don't like what I see, I'll just switch to a different drug, like prasugrel. So the FDA label doesn't recommend routine genotyping for CYP2C19 before clopidogrel use. It says, with known CYP2C19 polymorphism, well, how are you supposed to know? I mean, who's going to do the pharmacogenetic test unless you're going to do it for drug? So if you happen to know that this person, because they had a whole genome sequence from Illumina, and then they come to you with their printout, I'm not sure how you're supposed to do that anyway. So what are the obstacles to demonstrating utility in implementing pharmacogenetics? Many of these drugs are cheap generics, so there's little incentive to study or implement pharmacogenic decision making. Most of the studies are add-ons to clinical trials that are designed for a different purpose, and they often do not have the pharmacogenic information at the time of prescribing. I mean, a doctor doesn't want to have to wait to put their warfarin or clopidogrel, whatever they're going to use, for the test to come back. And also, this is a big problem. It's a lack of decision support in the EMR, electronic medical record. So I'm going to end with this. This is just a piece of, this is my own bit of calculation, and I'm curious as to what people think about it. I believe that there's a strong case to be made for widespread genetic screening in preconception. And this is why. We're already doing preconception testing of, you know, there's an Ashkenazi Jewish panel, there's a Caucasian panel for cystic fibrosis, there's a whole bunch of panels that people are using for preconception testing. And what that's based on basically is reasonably common alleles with a test that at one time was viewed as being fairly expensive. But once you drop the price to a very low point, why not do the following? So here's a bunch of disease incidents 1 in 10,000, 1 in 100,000, 1 in a million. And here's the carrier frequency. So this is an assumption that all the autosomal recessive diseases you're interested in all have this disease incidence and this carrier with this carrier frequency. All right, so these are 5 different scenarios. Of course, it's not the case. You know, if you looked at 1,000 autosomal recessive diseases, they're going to be different incidences. But what this shows you, what's the probability that both members of a couple are carriers for at least one autosomal recessive disease if you examined 100, 300, 1,000, and 3,000? If you look at 3,000 genes, the probability of them being a carrier for at least one disorder, if they were all as frequent as 1 in 10,000, which is too high, it's extremely high. But this is not so high, 10 to the minus 5. We're getting about a 10 to 12% chance that they're a carrier for at least one of them. Both are carriers for at least one of them. And compare this to cystic fibrosis. Sorry. Cystic fibrosis, which is here. Or Tay-Sachs disease, which is even lower. So I would argue that it is not appropriate that a couple at risk for having a child with a severe autosomal recessive condition should learn of their risk by having a child with a severe recessive condition. I think we can do better, and this is an area where I think screening can really be applied appropriately. Of course, recognizing that what you're doing is providing information which can lead to downstream medical costs, such as pre-implantation diagnosis or abortion. So I'm going to stop at that point. I'm stopped at what I think is a somewhat controversial statement about screening, and I'll be happy to take any questions. I went over a little bit, I'm sorry. Any questions? Yes, David. Yeah. Yep. 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 Yeah. So the question was, are there patients out there who are asymptomatic but have clear-cut pathogenic variants and that are simply not penetrant? So I think it's going to vary from patient to patient. Of course, some disorders we know very well can have penetrance as low as 20 or 30%, Brugada syndrome, SCN5A mutations. But the best example I know is Les Biesecker has done his ClinSeq project, where he sequenced a bunch of people, did whole exome sequence. He discovered a new, not a new, but he discovered a previously unrecognized disorder of malonic acidemia. Not methylmalonic, but malonic acidemia, which in the first patient, when they called her back, turns out she had mild neurological findings that no one had picked up on. But there were other people in that cohort who were completely asymptomatic. I think the question of whether deleterious variants picked up through families will turn out to have a higher penetrance. I think that needs to be tested, but I don't think it's unreasonable, given what we know about modifiers as well as environmental effects of growing up in the same family. Any other questions? Good. Okay, well, thank you very much. Oh, sorry. Tom, you have a question.
So, what about the green eye shades and the cost of screening?
You didn't see the green eye shades? I mean, what I basically said was I think that most pharmacogenetics is that people are touting, warfarin, clopidogrel, CYP2D6, on and on and on, are essentially not going to be implemented. Yet that was described as the low-hanging fruit. Oh. Yeah. I mean, part of the problem, I think, with that, you're absolutely right, is that there's actually been very little done on that. And the other problem with econometric studies on this is the cost of doing this is changing so rapidly. 3 years ago, if you wanted BRCA 1 and 2 from the laboratory that had the monopoly on it, it cost you over $3,000, not including rearrangement testing. Now you can have all of it for $950. So I think things are changing very fast. But I mean, you're absolutely right. You would like to see more quantitative green eye shades. And that, unfortunately, is not my field, but I agree with you completely. Tom, did you want to ask a question? Oh, because there's a question there. Yeah. Yeah. So first of all, by having extremely tight processes, so we can drive the cost of goods and services way down, and we've already succeeded in doing that, and we're on a trajectory to cut it in half over the next 2 years. So we can do this very cheaply, do panels very cheaply, and first of all. Second of all, we are putting all of our data into ClinVar. And so we think that sharing information is pre-competitive space. We don't think it's competitive space. And so, and we have other like-minded people who are doing that. And so I think together, we're going to drive the cost of medical interpretation, which is about a third of the cost of doing a test now. If you take the administrative cost out, the sort of problem of getting pre-authorizations and medical records and all that stuff, put that aside. About a third of the cost of the test is acquisition, about a third is the sequencing, and a third is the medical interpretation. The sequencing we can cut in half. If the medical interpretation could be cut in half, right now, I mean, our company will offer a panel of whatever size you want for a single indication for $950. And if the patient wants to pay for it so that we don't have to go through all the administrative headache, it's $475. So you can get a full breast cancer panel for $475 if you'll give a credit card. And I just think that those prices are actually on the way down. Anyway, that's my view of it. Does that partially answer your? Yeah. I've been accused of being a little bit histrionic about Myriad. But first of all, I was a consultant to the ACLU on the 3 lawsuits, the district court, the circuit court, and then the Supreme Court, and was deeply involved with those lawyers in getting the patent overturned. I really believe very strongly and was infuriated by the legal arguments that were being made by Myriad. Essentially, they were saying is that when a leaf is on a tree, it's a natural product. When you pick the leaf off the tree, it's no longer a natural product. I mean, I just thought it was intellectually dishonest. And second of all, if you read the AMA Code of Ethics, it is unethical to use trade secrets or proprietary information to inhibit the sharing of medical information. I can show you the specific reference to that. So from my point of view, it's not ethical behavior to call this stuff proprietary. And finally, there's the hypocrisy issue, which is Myriad is more than happy to participate in PROMPT and other initiatives to share information about breast cancer genes, except BRCA1 and 2. So they're happy to share information with other people about genes that they don't know that much about. So it's a combination of intellectual dishonesty, unethical, and hypocrisy. But that's my own personal opinion. It's not the opinion of anybody I represent. Yeah. Yeah, right, so Dr. Camper is just talking about how there should be a point where the economics are in favor of widespread preconception carrier testing, not just to reduce harms and to reduce risks, but also to that it actually makes sense economically. I'm sure that's true. I mean, right now there are companies that are offering 100 gene panels, but they're mainly looking at specific alleles. They're not sequencing for all of them. That are starting to be very widespread and used a lot in prenatal prenatal clinics. So I think it's only a matter of time. It is, however, all caught up in the big A issue, the abortion issue, which is, it's a serious issue in this country that we do not agree about this. Yeah. Mm-hmm. Right. So Dr. Innes is asking, what's the role of next generation sequencing in the newborn period, either as a replacement for or as an adjunct to the current screening? So I guess I'm going to restrict my comments only to the metabolic disorders that are picked up by MSMS. So that is a very, very cheap test. And to replace that with a test where we're going to get variants that we can't interpret, I think would be a much more expensive test that we can't interpret. I think would be foolhardy. Someday, Bill Gates said that it's easy to overestimate progress in the next 2 years and underestimate your progress in the next 10. So I don't know what's going to happen in 10 years. But that said, I think it's unlikely, at least in the near future, that sequencing is going to replace MSMS. We don't know enough about the sequencing, and et cetera. However, I do think it could play a major role as a second-tier test. The idea being you have particularly the 1/10 of babies in California who are born are in a NICU, where you have a very high false positive rate for MSMS. To be able to sort that out by sequencing and not have to have the baby go through weeks to months of dietary manipulation, follow-up with physicians, whatever, could actually be very cost-effective. There are also examples where the same pattern of metabolites could actually be due to more than one disorder, like glutaric acidemia. And so could we use sequencing to sort that out quickly and easily from the beginning? And then finally, even not in the newborn period, there are children who are born that have an abnormal screen. We don't know if it's a false positive or a true positive, and it takes sometimes weeks to months to come to a definitive diagnosis. And that's putting the child and the parents through the ringer, plus, of course, costing a lot of money. So I think it's going to play a role in that. And I think it's also going to do that in SCID. SCID is going to give us, a positive TREC, but then we're going to go right to screening a panel of 150 genes and know what the underlying genotype is. And we're already doing that for CF. Sequencing for CF, or at least genotyping for CF, is a second-tier test after the positive, right? So that's my feeling. That's where it belongs, as a second tier for now. Yeah, yeah.
You mentioned that about a third of the cost of a lot of these genomic tests is interpretation.
Yeah.
That seems very low compared to, the sequencing costs are really going down and have gone down dramatically. Whereas in at least many of the published studies, the interpretation costs of time and effort still remain high.
Yeah.
And I'm just wondering, what is the basis of your estimate of only a third of the cost?
So what is my estimate that only a third of the cost is the medical interpretation piece? And what that comes from is actually the data from my company. So what it really reflects is that if you have really good decision support software, that's sort of like the Bloomberg terminal of variance. It pulls everything in that you need. It does it quickly and simply so that the person who's doing the interpretation actually has all the data in front of them, doesn't have to, they talk about it requiring 20 hours per whatever. But that's because you're spending all this time going out and pulling data and pulling it down and getting a look at it. Once you combine the fact that there are tens to hundreds of thousands of variants in the public domain, we have internal data that's gone into ClinVar, but then also that you have good software decision support that pulls all this stuff together. It allows you to do it much more rapidly. So, and also I think that there's a certain amount of humility that needs to be put on into place when you're doing this interpretation, and not overinterpret. I mean, primum non nocere, first do no harm. So if you really are not sure that that variant is a pathogenic or likely pathogenic, then you shouldn't call it that.
Thank you very much.
You're welcome. Thank you.